Hi everyone, we'll be getting started shortly. We'll let a couple more people come in and then we'll get started. Okay, so Carol, do you want to give it about two more minutes for more people to come in? Does that sound
Yeah,
good? Okay.
yeah. For those that are on the line, if you could, in the chat box, please tell me what you do for a living. I try to tailor this presentation to who is attending, so I'd like to know what you do. You know, it looks like, Rashonda, it looks like attendees cannot, I can't send a chat to the attendees. I'm not sure.
Um,
Can you check the settings and see if attendees can write in the chat?
okay, let me see. Let's see if I can send it. Did you get that?
Yes.
Okay. Is everyone able to type in the chat? If so, could you all please type in what do you do for a living so that Carol could kind of tailor her presentation to what everyone does? That would be great.
See, I don't have the opportunity on my pull down menu I can send it to the organizers and the panelists, but I can't send it to everyone, to the entire audience. So I'm worried that the audience can't enter in the chat.
Let's see. Hmm. I don't know. That's so weird.
I see Shanrita is listed as a panelist, so she could probably enter in the chat, but
Mm.
oh well.
Well, if it Hopefully, the chats will come to me, and then I'll be able to.
Okay, that might
Yeah,
work. All right,
yeah.
I'll reduce the size of the chat. If they can send you, the organizer, a question, then you can monitor that. All right, we'll do it that way.
Okay, great.
All right. So
Okay.
why don't you do an introduction, and then we can get started?
Yep, sounds good.
Okay.
Okay, so hello everyone. Thank you for attending our webinar today on immunizations in the maternal child health field by Carol Hayes from Educating Physicians in the Communities. My name is Brichelle Parker, and I am the Perinatal Program Coordinator with Healthy Mothers, Healthy Babies Coalition of Georgia. I will be the moderator for the talk today. A bit on what this organization is about. The Healthy Mothers, Healthy Babies Coalition of Georgia, or HMHBGA, has been around since 1973. Our mission is to improve maternal and infant health through advocacy, education, and access to vital resources. We accomplish this through advocacy in collaboration with Georgia lawmakers and by serving Georgia communities in different ways. We are so excited for Carol to lead our session today. Please familiarize yourself with the chat box, and we will have around 10 minutes or so in the end to ask all these questions. With that, I turn it over to Carol Hayes.
Hi, everyone. My name is Carol Hayes. I'm a certified nurse midwife, and I have been for 33 years. I've worked in a variety of settings. I currently represent the American College of Nurse Midwives at the CDC Advisory Committee on Immunization Practice, which we're going to talk about in a minute. So I'd just like to acknowledge that this presentation is supported by a grant from the Georgia Department of Public Health, and it is organized with the Georgia chapter of the American Academy of Pediatrics and the Georgia OBGYN Society. So the material that is being presented today has been reviewed by them. I have no conflicts of interest in this presentation. Our objectives today are that people will understand what is entailed in providing immunizations in a practice. And I was hoping to find out what everyone did for a living so that I could kind of tailor it to that, but I don't know if that's going to work out. But we're going to talk just a minute about the adult immunization schedule. We're going to talk quite a bit about making a strong recommendation for vaccines in pregnant women, and to summarize the CDC's recommendations for vaccine storage and handling, and to come up with a workflow in a practice, and to talk a little bit about financial analysis. So the American College of Obstetricians and Gynecologists, as well as the American College of Nurse Midwives, recommends assessment of immunization status. This immunization status should be looked at as part of any routine screening. So anytime a woman is seen in the office for any reason, it doesn't matter, she should be evaluated on where she stands in her immunization status. Sometimes, for many women, going to a women's healthcare provider is the only time they see a healthcare person. They don't necessarily have a primary care group that they go to. So many times women's health is where they get their primary care. And so in women's health, we have an opportunity to decrease the likelihood of influenza during pregnancy, and we help babies be protected by the woman getting Tdap, and we can offer a human papilloma virus vaccine and the hepatitis B vaccine. The Advisory Committee on Immunization Practice is a group of scientists that are appointed by the U.S. Secretary of Health and Human Services. They review data, they have meetings regularly, the meetings are open to the public. These 15 voting members then advise the CDC on what immunizations are recommended in the country. Once the ACIP has voted on making a recommendation on a vaccine, then insurance is required to pay for it. The ACIP adopts the schedules and what's on the schedule, and they review the latest trends in infectious diseases and any research that's going on with vaccines. Their meetings are held typically 3 times a year for 2 days. However, since COVID, we've been meeting monthly. I am not on the committee. The committee has what's called liaisons, and so I represent the American College of Nurse Midwives as a liaison, and I attend their meetings, and I am part of the conversation, but I am not on the committee. So the 2021 immunization schedule is, we have one for adults and one for children. The more we are able to produce vaccines, the busier this schedule gets. And they have tried this past year to change the way that the schedule looks. They've tried to make it a little bit easier to understand. And when they made it easier to understand and easier to look at, however, a lot of the details got sort of moved off of the schedule, and they are now in the footnotes. And the footnotes are quite lengthy. So anytime you're recommending a vaccine or anytime you have a question about the vaccine, don't just look at the schedule, but read the footnotes, because there's a lot of really important information in the footnotes. So the first immunization we're going to discuss is influenza. So influenza affects between 10 and 20% of the population every year. It's easily spread through droplets in the air. The wonderful thing is that all the mask wearing that we've been doing in the last year has reduced the amount of influenza in general. So typically we have thousands of deaths in children from influenza every year. This year we had 1 death in a child from influenza. So the physical distancing and the mask wearing that we've been doing have helped reduce not just COVID, but also influenza. Influenza has responsible for significant illnesses. You know, I'm sorry, but the pollen, as we all know, is a little rough today, although it's getting better with the rain, but excuse me. Just need a little sip of water there. The influenza season in the United States typically runs from October through May, with peak activity in December, January, February, and March. Vaccines are offered to pregnant women, but many pregnant women are not taking up the recommendations. And many times we find that only about half of pregnant women are receiving a flu shot, and only about half of women are receiving a Tdap vaccine during pregnancy, and only about 1/3 of women are getting both of these. So influenza begins with an abrupt onset of fever, headaches, myalgia, malaise, and pregnant women are at risk for severe illness if they acquire influenza while pregnancy, and that has to do with the biodynamics of pregnancy. And their risk of getting sick increases with each trimester because of how the body adapts to pregnancy. The ACIP recommends that all persons 6 months of age and older, including pregnant women, receive a flu vaccine every fall. But only about half of pregnant women are getting their vaccines. And the reasons that women list as to why they're not getting them is that they have a lack of knowledge about the seriousness of influenza. They say, oh, I've never had the flu in the past. Why should I worry about getting the vaccine? Some women have concerns about the safety of the vaccine. Some women have a fear of needles. Some have lack of insurance or lack of access to care. And some women report a general mistrust of the medical profession. However, one of the main reasons that women report for not getting a vaccine during pregnancy, a flu vaccine, is that their healthcare provider did not recommend the vaccine. So the influenza vaccination during pregnancy reduces the risk that not only the pregnant woman will become ill, but we do know that anytime a woman has a fever in pregnancy, that it influences the fetus in a negative way. So we want to try to prevent fever in pregnancy. And so if we can prevent the flu in pregnancy, we can prevent febrile illnesses as well. So vaccinating the mother also protects the newborn, because she passes her antibodies across the placenta, and then the baby is born with these antibodies. So we're literally vaccinating 3 people when we give a pregnant woman the vaccine. We're vaccinating the woman, we're vaccinating her fetus, who and then becomes her newborn. And so that means that we're having like a double, triple whammy when we protect the pregnant woman. We have been recommending and giving the flu vaccine to pregnant women since the 1950s. So that's 60 years of giving the flu vaccine. There's no evidence that there's any teratogenicity or risk of insult to the fetus. And the pregnant woman can be vaccinated at any time during pregnancy, even in the first trimester. So the changes in the immune system with the heart and the lungs during pregnancy make them more at risk. And the side effects of the flu shot, the common side effects are the same for a pregnant woman: soreness, redness, swelling at the site, headache, muscle aches, nausea, fatigue. And we try to prevent women from having a fever. So if she does develop a fever, she needs to take Tylenol. So a pregnant woman who has an egg allergy can still get vaccinated. And we have many different ways of monitoring vaccine safety. The two most common ones are the Vaccine Adverse Event Reporting System, VAERS, which is developed through the FDA and the CDC. And then there's the Vaccine Safety Data Link, and this is a collaboration with 9 healthcare organizations, including some HMOs, some big HMOs, and some other large health systems in the country that collect data and send it to CDC. There's also the Vaccine and Medications in Pregnancy System, which is a national system that anyone can report an adverse event. We've changed the flu vaccine composition every year, and the reason that we do that is because different variants of the flu float around every year. So the World Health Organization sort of monitors what's going on in the summer. In our summer, it is winter in the Southern Hemisphere, and so the World Health Organization looks at the trends of what strains of the flu are floating around in the Southern Hemisphere in the summer, and then they develop the vaccine based on that. So what's in the vaccine changes from year to year. And this is one of the reasons why we have a lot of times people say, well, I got the flu vaccine, but I got the flu anyway. And the main reason that that happens is that that vaccine that year was not necessarily protecting against the strains of the flu virus that were floating around that year. We call this antigenic drift. So we did a bad job of designing the vaccine. It doesn't mean the vaccine doesn't work. It means that that year we missed the target on what should be in the vaccine. So there is a trivalent vaccine, which has 3 lines in it, and then there's a quadrivalent, which has a 4th line in it. Most of the time when people are ordering the flu vaccine, most organizations, health organizations and pharmacies are ordering the quadrivalent vaccine. The ACIP recommends the annual flu vaccine for all persons 6 months of age and older who do not have any contraindications. So the current manufacturers that we have on the market right now, we also have a high dose flu vaccine for people over 65. The younger you are when you get a flu vaccine, the stronger your immune response is to it. The older you are when you get a flu vaccine, the less, and this is true for any vaccine actually, the less your immune response is. So we have a special vaccine for people that are over 65. The live attenuated vaccine, also known as flu mist, should never be given to a pregnant woman. Pregnant women should never have any live vaccine. So this can be given to people who are not pregnant, but we don't give it to pregnant women. So we recommend that when we're making a vaccine recommendation, we make a strong recommendation, and that is the acronym is SHARE. So it's sharing information, highlighting, addressing concerns, reminding, and explaining. So we're going to go over that now. So when you share reasons why the flu vaccine is important, given the patient's age, health status, lifestyle, occupation, and other risk factors, you can say things like, this vaccine can protect you and your family from getting sick. By getting the shot today, you can be protecting yourself and the people around you who are most vulnerable to serious flu-like illnesses, like your elderly parents or your children. So we get the flu vaccine and we get the COVID vaccine because we want to protect not just ourselves, but the community and the family that we live with. You want to highlight the positive experiences. What I say to people is, you know, I've been getting the flu vaccine every year for the last 25 years, and I have only had the flu once. So I feel really blessed that, and their theory about this is because the component of the vaccine changes every year, I am building up immunities to many different strains of the flu. So even if the vaccine that I get this year, the circulating strains are not matched up, maybe it matches up with the vaccine I got last year. So you want to address what the patient's concerns and questions are. And people have lots of concerns and questions. So you sort of open it up with an open-ended question. Ask them to tell you what their concerns are. The most important misinformation that is out there is that the flu shot gives you the flu. The only time that this could have a relevant is if the person got vaccinated on Monday, and it takes about 2 weeks for the vaccine to kick in and become effective. So if you got the vaccine on Monday, but you were exposed to the flu on Monday, you are still going to come down with the flu on Wednesday. So the flu vaccine does not cause the flu, but there could have been a bad timing on when you got the vaccine and you get the flu shot anyway. And the flu anytime you receive a vaccine that is inactivated, you cannot get the disease from the flu vaccine. It's an inactivated vaccine, except the live virus, the live mist vaccine, but it still cannot cause the flu. Most side effects to the influenza vaccine are mild. Typically, it's pain and swelling at the site of the injection are the main symptoms that people report. So then you want to remind patients, and this is an opportunity to revisit every time you see a patient, whether or not they've been vaccinated. So you want to bring it up each time they're seen in the clinic. And you can have different ways of bringing it up each time, a different angle maybe to kind of address what their concerns are or discuss what the dangers are. And I think a lot of people confuse it. They think the vaccine is dangerous instead of thinking that the disease is dangerous. So we want to explain the potential costs of getting the flu, including missing work, serious health effects, and that way you're saving time, money, and energy if you get the vaccine. So the next disease and vaccine that we're going to discuss is the tetanus, diphtheria, and acellular pertussis vaccine. We don't see tetanus or pertussis or diphtheria very much anymore because we have been giving these vaccines for a few years. However, we have a lot of people who are leery of it, so we have seen a huge increase in pertussis over the last few years. And I just want to play a little clip of what it sounds like to have pertussis. So when a child has pertussis, they are literally gasping for air, and that's that ooh whooping that they do. It's a terrible sound. So the Tdap vaccine is for adults. Dtap is for children. And there are two products on the market for a Tdap vaccine that can be given either of these can be given to pregnant women. And the reason that we want to recommend this is ACIP recommends that there's one dose of Tdap in each and every pregnancy, and that's regardless. And the reason is that this is a terrible vaccine. It's incredibly safe. So they got rid of a vaccine a few years ago that was very effective, but it had a lot of side effects, and so they got rid of it. So they came up with this vaccine. The problem with this vaccine is that our immunity, our antibodies to pertussis wear off very, very quickly. So the tetanus part of the vaccine lasts for a long time, diphtheria lasts for a long time, but the pertussis part does not. And so we want to revaccinate pregnant women in each and every pregnancy because we want to make sure that they have current, up-to-date, good antibodies that are available for their fetus and their newborn. We are not vaccinating the pregnant woman because we want to protect her. We are vaccinating her because we want to protect her newborn. The best time to get this is the earliest in the third trimester that it's possible. So the CDC recommends it between 27 and 36 weeks, but the earlier, closer to 27 weeks, will maximize that positive antibody transfer to the fetus and to the infant. This is shown to be 80 to 90% effective at preventing pertussis in newborns. So pertussis deaths, as you can see, have gone down. We have had a surge in the early 2000s, but the problem is most of the time these cases in young children are causing the deaths. So if these children are not eligible to be vaccinated until they're a few months old, and so that's when they tend to die. Is if they get pertussis when they're young, when they're new, that's when they die. And so we're trying to prevent deaths of newborn by vaccinating the mom while she's pregnant. So if you do not keep Tdap in your clinic or the flu vaccine in your clinic, you want to make a referral. And the best way to do this is to convey to your patient that even though you don't have the time, energy, money, resources to keep vaccines in your office, you still want to make sure that you're recommending it to them. And so you can I usually write a prescription out and I say, here, take this to the local pharmacist. When we first started these recommendations about 5 years ago, a lot of pharmacies were really hesitant to vaccinate pregnant women. And so the prescription really made a huge difference, that they felt like, okay, I'm getting this recommendation. The patient isn't just asking for it, but they actually have a prescription for it. And so we've been working really hard with the pharmacists to help educate them about the safety of these vaccines in pregnancy. So the CDC, Acog, and Acnm recommend that pregnant women are vaccinated against flu and pertussis in each and every pregnancy. You want to re-emphasize that just because you don't keep in stock doesn't mean that you don't think that they're important. And there is a wonderful vaccine health map that a patient can go to that can help them find the vaccines that they need in their community. So the key messages are we want to promote the expectant mother the chance of having a healthy pregnancy and a healthy newborn, and that when we vaccinate her, we are also vaccinating her, her baby. So she's doing this to help protect her baby, not just herself. So now we're going to discuss the SARS-CoV-2 virus, which is also known as the COVID-19 virus. Transmission is through droplet and respiratory spread. Back a year ago, when we first had this pandemic begin worldwide, we didn't really understand how it got transmitted, and so we have a much better understanding of it. We think that the virus does not live very long on inanimate objects. So last year we were wiping all of our groceries down, and we really don't have to do that anymore. It's really about wearing a mask because this is easily transmitted through your nose. And when I see people not wearing their mask around their nose, what I usually say to them is, be careful, you get COVID through your nose. So I'm sort of putting it back on them. I'm not criticizing them for wearing their mask wrongly. I'm saying you need to protect yourself, and you're not doing it by wearing your mask around your chin. So it's not their mouth that we need to protect, it's the nose that we need to protect. So the COVID-19 disease, as we all know, fever, chills, cough, shortness of breath, fatigue, headache, myalgia. So a lot of people have GI symptoms. I lost a colleague that I used to work with. She had severe GI symptoms and ended up dying of fatty liver disease from her COVID infection. So you can have many different ways that this manifests, but shortness of breath is the biggest thing that we have to worry about because we know that you could develop pneumonia when you develop shortness of breath. Loss of taste or smell is quite common. And for some people that have mild cases, that sometimes is the only symptom that they have. We have had a fabulous result with Operation Warp Speed on the federal level, putting massive amounts of money into vaccine development for COVID-19. And the research that was done on this was not done in a lot of people are concerned about how quickly this was developed. They did not cut any corners. What they did was they overlaid. Typically, vaccine and drug development, they'll do phase 1 for a year, then they'll do phase 2 for a year, then they'll do phase 3 for a year. What they did with all 3 of the vaccines that have been approved in emergency approval by the FDA, they did phase 1, phase 2, and phase 3 all at the same time. So what we were able to do was get data back very quickly on how effective they are. There's a couple of differences in these 3 vaccines, and so we're going to talk about those. The most important difference is that the Pfizer vaccine must be stored at -80 degrees Celsius, which is like Antarctica cold. Moderna can be stored in a normal freezer, and the Johnson & Johnson Janssen vaccine can be stored in a refrigerator. The other difference in these 3 vaccines is that Pfizer requires 2 doses, Moderna requires 2 doses, and the Janssen vaccine only requires 1 dose. The other difference is how they're made. So we're going to go over that a little bit more here. So the mRNA vaccines, they've been working on an mRNA vaccine for at least 25 years in the lab, but they've never developed one for humans, but they've been working on it. So this is not a new technology, but it is new to humans. So this is when they first developed this vaccine a year ago, started working on it a year ago. As soon as China revealed what the DNA was for the virus, 2 companies decided, we're going to extract that DNA, then we're going to take the messenger RNA that tells it how to replicate, and we're going to use that messenger RNA to make a vaccine. Some important myths and facts about the mRNA vaccines is that they cannot give anyone COVID-19. They do not use a live virus that causes COVID-19. They do not affect or interact with our DNA in any way, shape, or form. The mRNA never enters the nucleus of the cell. What it does is, which is where our genetic material is kept, it works in a different way. it takes the messenger RNA and it convinces the lymph node, hey, I'm your enemy. You need to see me as your enemy, and you need to work to make an antibody against me. And then literally the mRNA itself disintegrates and it's gone, and you don't see it in the body anywhere. So another distinction is that the Pfizer vaccine has been approved by the FDA for 16 and older. The Moderna is only for 18 and older. So we have a few differences. Also, when you're administering the vaccine, the Pfizer vaccine is a very different dose. It's 1/3 of an ml, whereas Moderna is 1/2 of an ml. The multi-dose vial for the Pfizer comes, you have to have a diluent. So it comes, and the diluent comes in the box. You load it all up together, and you can get 5, sometimes 6 doses out of a vial. With Moderna, it comes pre-mixed. You just pull up the injection of 1/2 of an ml. Another big distinction is that the Pfizer vaccine is given every 21 days, and Moderna is given separated by 28 days. Not every 20. I'm sorry, not given every 21 days, but the 2 doses are separated. At Pfizer at 3 weeks and Moderna at 4 weeks. So the Johnson & Johnson Janssen vaccine is a non-replicating viral vector vaccine. And this is a very common vaccine. We've been using these types of vaccines for years. They use a modified version of a different virus to then trigger the gene response and trigger our body to make antibodies. So again, the viral vector vaccines do not cause COVID-19. The genetic material does not enter the cell nucleus. It does not change our DNA in any way. They have been well studied for many decades in clinical trials. Other viral vector vaccines have. And this is the Ebola vaccine that we developed, also developed by Janssen. The vaccine for the Janssen vaccine is approved for 18 and over. Another big difference is, I'm just going to go back for a minute to a previous slide. We know that with both Pfizer and Moderna, they are 95% effective, and they have a new study that got released this week that said both of these vaccines, they did swabs in the nasal area of healthcare workers that were given the vaccine early in the clinical research trials, and we knew that they were healthcare workers, so they were getting exposed at work. And what they found was that a few people came down with COVID even after they've been vaccinated, but they didn't ever get very sick. And so that's wonderful news. And so we have this very good efficacy. There's a 95% chance that if you've been vaccinated with these mRNA vaccines, that you will not come down with it. And if you do come down with it, you have a very mild case. We have a little bit of a difference in the Janssen vaccine. It's not quite as effective at preventing disease, but we do know that it is incredibly effective at preventing severe illness, hospitalization, and death. So don't think of it as an inferior vaccine. It is a good vaccine. It's going to be great for resource poor areas because it can be stored in a regular refrigerator. It also is only 1 dose, so it's going to be great for populations where we have a hard time with getting them back in for their 2nd dose. So it's a good vaccine. It comes in a multi-dose vial, and it's a 1/2 of an ml. There are some other very important distinctions with the mRNA vaccines about what you have to do once you've pierced the vial and once you've mixed the diluent in. And so if you do order these vaccines in your clinic, you are recommended to take the CDC vaccine storage and handling training that they offer. So there is a 1-page education brochure that the CDC has developed along with the Immunization Action Coalition. There's one for the Pfizer vaccine, one for the Mrna vaccine, and one for the Janssen vaccine. And so I highly recommend that if you're giving these vaccines, that you keep these in your clinic. So the CDC and Acog have come up with a recommendation that looks at as pregnancy in vaccinating pregnant women and lactating women with these vaccines. We have some really good data because we have a lot of nurses that got this vaccine that were pregnant. So we have wonderful data demonstrating that it is safe and effective to give these vaccines in pregnancy. the data is still coming in, but Acog recommends the vaccine should not be withheld. So there have been reports of pregnant women wanting to get vaccinated, and the people that were giving the vaccines were hesitant or leery to vaccinate them. So we know that they're safe. They haven't come out with a strong recommendation about it yet because they're waiting for more data to come in. But there is a pregnancy registry looking at this, and pregnancy testing should not be required before receiving the COVID vaccine. ACOG recommends vaccinating persons who are actively trying to become pregnant, and there's no evidence of any effect on fertility. That was another myth that went around, that these were going to affect your fertility. So other things to keep in mind is that these vaccines are not interchangeable. So you can't receive the Pfizer first and then for your second dose try to get the Moderna. And you can't have any other vaccine at that same visit. The CDC recommends that you wait 14 days between the COVID vaccine and any other vaccine. So that's, if you had another vaccine, you have to wait 14 days to get the COVID vaccine. And if you've had the COVID vaccine, you have to wait 14 days to get another vaccine. We don't know yet if we're going to need a booster to these vaccines, but they are continuing to collect data on the people who were in the clinical trial last year on how long their immunity lasts. So hold that, we'll know more next year. We do know that the vaccine can be given safely to people who have previously been infected with SARS-CoV-2. We have, however, had some preliminary reports that some people said their second dose made them feel really bad if they've had SARS-CoV-2. And other people have reported that they felt better after their second dose. So we don't know yet what that is, and so they're continuing to monitor this very closely. CDC is. So contraindications are a person with a severe allergic reaction of anaphylaxis to any vaccine should not get the COVID vaccine. If they've had an immediate allergic reaction to any other type of the vaccines, then we want to be very cautious with that. People with a contraindication to one type of the currently authorized vaccines, for instance, if they've had an anaphylaxis, they have to use precaution with the other one. And so they're still looking at what these contraindications are. And the polysorbate 80 is found in the Janssen vaccine, and there's some worry about people being allergic to that. And there's a lipid profile in the Pfizer vaccine that's a little bit different than the lipid profile that's in their stabilizers, that's different than the Moderna. So we have seen a little bit more anaphylaxis reaction than people that have had the Pfizer vaccine, but it's still an incredibly safe vaccine. Precautions that need to be taken are persons with a history of immediate allergic reaction, or people with a reaction to a vaccine that have multiple components in it. Sorry about that. Thought I had turned that off. So neither contraindications nor precautions. So allergic reactions, including severe allergic reactions not related to the vaccines or to injectable therapies, but other things like food, pets, allergies to pollen. We don't have to worry about any of that, or medication allergies. None of that affects getting a vaccine. The vaccines are not made with natural rubber latex, and so there's no worry about latex allergies, and neither are the lids to the vaccines, the pierceable top to the vial. They don't contain any egg or gelatin, so we don't have to worry about any of that. They do, however, recommend that if somebody has ever had a severe allergic reaction, that after the COVID vaccines, that they wait 30 minutes after being vaccinated at the clinical site before leaving. If they've had any history of anaphylaxis due to any cause, they need to wait 30 minutes. Other people, it's just recommended that they wait 15 minutes. In all the vaccine clinics that I've worked, the COVID vaccine clinics that I've worked, I have not seen any side effects at all in the clinic. Now, I've seen people have side effects the next day, sore arm, all those things, but I have not seen any adverse events in anybody in the clinic. The most common reactions to this are local reactions. Pain, redness, and swelling is very common. Systemic reactions, fatigue, headache, chills, fever, muscle pain, nausea, diarrhea all of those can happen, and they are more pronounced after the second vaccine than they are after the first vaccine. Vaccine adverse events should be reported to VAERS or through vSafe. And so vSafe is a post-vaccination monitoring system that the CDC has set up on your smartphone. You go to the internet and you type in vsafe.cdc.gov, and then you register, and then every day the CDC will text you and they will say, how are you doing today? What kind of side effects are you having? So this is a post-vaccination monitoring system, a voluntary system. You can opt out at any time, but it is allowing the CDC to collect more data after the clinical trials on what kind of reactions people are having. They're also ask you if you're pregnant on this a couple of times. So it's every day for a week, every week for a month, and then it's at 2 months, 3 months, 6 months, and 12 months. And you can opt out at any time, but it's a great way to gather more data about what the side effects are to these COVID-19 vaccines. I'm going to quickly run through hepatitis B because adding COVID to this presentation has made it a lot longer than it used to be. Hepatitis B vaccine is easily transmitted through a drop of blood onto a hangnail, and so that's why we've been recommending that children get a routine hepatitis B. If a woman has not previously been vaccinated against hepatitis B, she should be vaccinated, and the ACIP recommends 2 doses to all newborns. And then unvaccinated children under age 19, and persons with a history of sexual exposure, persons with a history of exposure to blood, which is why all healthcare providers have to have hepatitis B vaccine before we can work. Current and recent injection drug users, and they're currently debating making it recommended for all adults that didn't receive it as children. So it's also recommended if there's someone living in the household that is positive for infectious hepatitis, people that live in long-term care facilities or work with the disabled, people who are in hemodialysis, people who have diabetes, international travelers, people who have HIV, incarcerated persons. So lots of people are recommended to get this vaccine. It is considered safe in pregnancy, and so we do recommend if she has it. We're trying to prevent perinatal transmission of hepatitis B, which is why we test all pregnant women to see if they're antigen positive, to see if they are infectious. And if they are, then we give the baby hepatitis B vaccine and HBIG within 12 hours of birth. Human papilloma virus is a virus that we know causes simple things like the common wart. It can also cause mucosal and genital warts. It is the main cause of cervical cancer, anogenital cancer, oropharyngeal cancer, and it can cause laryngeal papilloma disease and low-grade cervical disease. So we have, wonderfully, a vaccine that protects against 9 strains of this. 2 of them are against the type that causes just the external mucosal warts on the genital area. The rest are to prevent the high-risk types of the virus that cause cancer. So Gardasil is now licensed for all persons ages 9 through 45. The American Academy of Pediatrics has recommended a tween visit for children at 11 to 12, and there's a couple of other vaccines that are recommended for children at that same time. The earlier that someone is vaccinated, the stronger their vaccine response. And so based on when you start the vaccine series is whether you get 2 doses of the vaccine or 3 doses of the vaccine. It's the 3 dose if you wait until 15. If you get started at 11 or 12, then it is just a 2-dose vaccine. So there's that information about the dose schedule. So Acog recommends that sexually active men and women who have previously had abnormal cervical cytology or genital warts receive the vaccine. They should be counseled that the vaccine may be less effective if they've been exposed to HPV before being vaccinated. This is another reason why we want to give this to what we call naive tweens. We want to vaccinate them before they're sexually active so that we can protect them before they're sexually active. So now we're going to talk a minute about what critical elements are for an immunization service if you choose to vaccinate in your situation. So we want to set a good example. So our role as a healthcare provider is to get vaccinated ourselves. I actually got a metal button made that said I've been vaccinated against COVID, and I wear it everywhere to sort of advertise that I'm vaccinated. We want to start a place of empathy and understanding. So when we have a conversation with someone, we want to talk about what their fears, their concerns are. We want to talk about the side effects. We want to be honest about the side effects. We want to listen, and listening is very, very important. So there are lots of training opportunities available if you want to give the COVID-19 vaccines. And there are some resources available on these sites. And you can also go to the Georgia Department of Public Health and find the sites. And the state is now opening up the vaccine to the general population. So there's a lot of problems with the way vaccines being stored, causing the vaccine to lose its potency. So we want to recommend that people only enter into this with the true commitment to keeping these vaccines stored the way they need to be stored. And obviously we don't reuse needles. So we have the recommended vaccines for healthcare personnel include hepatitis B, influenza, the MMR, varicella, tetanus, diphtheria, and pertussis, meningococcal for those that work in certain microbiology labs, and the COVID-19 vaccine. So I redid these slides in the order, and I missed this slide. It's out of sync. Sorry about that. So when we're looking at immunizing people that are have not previously been vaccinated for hepatitis B, we want to look at their antibody levels. And so we have had some problems with some people that got vaccinated that they didn't respond well to the vaccine, and so we're having to revaccinate them. And so this slide sort of describes, if you have somebody that was a non-responder, how you go about. This was recommended by the CDC a couple of years ago. So we have new updated vaccine storage and handling recommendations. And we have to use a standalone refrigerator and a standalone freezer unit to store vaccines. You cannot use a combined refrigerator freezer. You cannot use a home refrigerator. You have to use a refrigerator that's meant to store vaccines. And you cannot use a bar style refrigerator freezer or a dormitory style refrigerator or freezer. And the probe should be calibrated every 1 to 2 years. So you have to buy a specific probe that measures the temperature of the refrigerator and the freezer. And then you're supposed to use a digital data log to record what the temperature in the refrigerator and the freezer is every day. Nothing else should be stored in that refrigerator except vaccines and medications. Each vaccine has a different requirement, but the correct range for a refrigerator is between 36 and 46. And for a freezer, it's -58 Fahrenheit to +5 Fahrenheit. So we have to keep these machines in the proper temperature, or the vaccines are no longer effective. You have to maintain your temperature logs for up to 3 years. And you have to implement a vaccine emergency system. If the refrigerator or the freezer goes out of range, then those vaccines have to be destroyed. So do not, see. So always document. We have a couple of things that we have to do. In children, we have to be sure to give them the VIS. We're not required to do that in adults, but the VIS should be the most up-to-date one, and the CDC updates them regularly. And so you need to make sure that when you administer the vaccine that you include the date of the publication. So what year was that VIS published? And I have to say the Immunization Action Coalition has translated the VISs into like 25 different languages. So if you work in an international community, I highly recommend that you save their website in your web favorites. And then the person administering the vaccine, the practice address, and the name all goes into your documentation. GRITS is the Georgia Registry of Immunization Transactions and Services. It is what we call a birth to death immunization registry. It allows providers who administer vaccines to enter in the vaccine, and so that person's record can transfer. Anybody can look it up. As long as you got a username and password from GRITS, you can monitor what someone's vaccine status is. If you are administering vaccines, I highly recommend that you get a username and password. This system is a computer-based system that was developed 20 years ago. The software on it is horribly out of date. So the good news is that this year in the general legislature, one of the reasons that Georgia is 49th in administering vaccines is because our GRITS is so outdated that we were not able to adequately transfer data to the CDC and to the HHS to then get more doses. So we were behind starting in December. We were the last state in the country to get vaccines in a timely manner because of GRITS. So the good news is the state legislature has pumped a bunch of money into GRITS, and they're going to redo it. And so hopefully this system will be greatly improved. The GRITS personnel can work with your EHR vendor to create an interface so that if you've entered a vaccine into your EHR, it can then get sent straight over to GRITS. And so like if you get your flu vaccine at Publix, they participate in GRITS. And so then your healthcare provider can log into GRITS and see that you've been vaccinated against the flu vaccine, maybe not at their office, but you got it at the grocery store. So we have vaccine safety monitoring systems. We have VAERS. We have the FDA Vaccine Data Safety Link project, and we also have the vaccine error reporting system. So we have a lot of ways of monitoring vaccine safety. And the data is published on this regularly through the CDC MMWR. So if you want to set your office up to provide immunizations to others, you want to make sure that you spend quite a bit of time planning to do this, purchasing the proper supplies, purchasing the proper syringes to give vaccines, making sure that you have the proper equipment to store the vaccines, and that you have the proper software and or paperwork for administering the vaccines and documenting. So you want to do what's a financial analysis. There's a resource kit for that where you look at what your practice needs to do in order to be prepared to give to set up a vaccination system, immunization service. You also want to try to recruit a vaccine coordinator. You want to make sure that there's one person in the office that is responsible for checking expiration dates, checking how much you have on supply and when do you need to order it and what your usage is and how many you're using per week, and do you need to order more 1 month and less 1 month. So you need one person that is coordinating all of that, doing the inventory, and making sure that the forms are up to date and that the reference materials for the clinicians are up to date, and creating standing orders so that if somebody walks in and the MA that's checking them in says, have you had your flu vaccine? And they say no, that MA can automatically give the flu vaccine without having to go find a provider and say, is it okay if I give the flu vaccine? So standing orders are a great way to get an MA to vaccinate people before the provider even sees them. You want to plan your workflow in your workspace, so it's better to have the vaccines in an area that have an emergency electrical supply in case the building loses power. Not everybody can afford to do that, but if you can, that is great. You want to do staff training so that you make sure that everybody in the clinic is up to speed on how to promote vaccines, the safety of vaccines, how you give a vaccine, what part of the muscle you give it in, making sure everybody understands what the parameters of the deltoid are. I gave vaccines with the nursing students last week at Georgia State, and they cracked me up how long they take to measure how far down from the acromion process and how above the V of deltoid, and they have to measure it 4 times to give it, but I was so proud of them. They did a great job. But you want to, I've seen people that didn't know what they were doing give the vaccine not in the deltoid, and it doesn't work if you don't give it in the deltoid. And we give all the vaccines, the flu, Tdap, and the COVID vaccine are all given in the deltoid. So it's Hep B, everything is given in the deltoid. So you want to have posters and fact sheets available, and you want to have community resources. So consider keeping these vaccines in your office: annual influenza for all patients, Tdap for pregnant women and anyone planning to have a child, HPV vaccine for all women through age 45, and the hepatitis B vaccine for women at risk. So you also want to try to estimate the total number of doses of vaccine required so that you're can't anticipate what your inventory is going to need to be. So you want, in purchasing, you want to set up the purchasing. You want to look at a spreadsheet for the prices, the terms, the discounts, the rebates, and a lot of companies have a rebate system that if you order it in a certain way, you get rebates. And you can, making sure that you have purchased the right thermometers and the right storage equipment and the emergency response supplies. So you need an EpiPen, you need some Benadryl and some Tylenol. When I walked through the drugstore near my house the other day, someone had just gotten a vaccine and they had fainted. And I said to their spouse, I said, did he eat breakfast this morning? And she said, no. And I said, all right, go get him some orange juice and some wet paper towels. And the pharmacist said, oh, thank you so much. I'm so glad you walked in. So I have to laugh. You know, sometimes if people don't eat before they come in and they faint, sometimes you need a little candy in your office too, or a little juice. So immunizations as a profit center, if you do this right, and if you have a high enough volume practice, then you can make money off of it. However, a lot of people don't provide immunizations because they know how much work it is, and it takes extra work from the staff. And so you have to figure out if it's going to work for you financially. So you have to calculate the average reimbursement for each vaccine, what the administration fees are, the net revenue. And so you have to keep up with these changes in coding too. And my God, coding, it gets worse every year, doesn't it? So you have to code for the vaccine administration, not just the vaccine itself, but the fact that somebody gave it, and you have to give the right diagnosis. And so coding for the COVID-19 services, there are ways to put in these eligible codes. They became effective in January of this year. And some places you can get funding back if you've submitted claims that DCH will help with these processes. But it should have been processing to be completed by today. Oh well. So stay current, stay up to date on listservs. The immunize.org has a great newsletter. CDC has a lot of information on their website. The Children's Hospital of Philadelphia has a great resource for children's vaccines. And making sure that your entire team is caught up. So discussing with your staff who has been vaccinated. And so online resources include the CDC vaccine tool guide for parents, then vaccine labels to organize your storage unit. Those are great. And the CDC vaccine information system, the VIS, the statements, and the refusal to vaccinate. The American Academy of Pediatrics has one of those. Standing orders, ask the experts. And Acog has a lot of resources on vaccinating pregnant and lactating patients against COVID-19. The American College of Obstetricians and Gynecologists, along with ACNM and the American Academy of Family Physicians and the Association of Women's Health and Neonatal Nurses have formed a task force, and they have written an immunization, a call to action for vaccinating pregnant women. And it's a wonderful document that promotes why pregnant women need to be vaccinated. The American College of Nurse Midwives also has a wonderful resource page that has patient education materials. It has Supermom campaign materials with posters and coloring books and all kinds of fun stuff on there. And I will open it up to questions.
Hi, Carol. Let me see here.
Also, this grant that this presentation was done on, they also have a presentation on breastfeeding that we would love to send someone to your clinic to do a presentation on breastfeeding if anybody's interested.
Okay. We have a couple of questions here. Someone said, you mentioned that some providers just don't bring up the flu vaccine to pregnant people in office. Is there a reason for that?
You know, I have not read very much about vaccine hesitancy among providers, why they don't bring it up. That's an excellent question. I wish I knew the answer to that. I need to get somebody to do that research.
Okay, so our next question is, are there certain areas of Georgia that are less likely to get vaccinated in general due to hesitation or just lack of access?
Um, Interestingly enough, I don't have any data on Georgia specifically, but I can tell you that historically, people of color are vaccinated less often than people of European descent.
Mhm.
So if you have communities of color, you're going to see less vaccine in communities of color than you do in white communities.
Okay. Next question. How should we share easy how should we share easy to understand information about vaccinations over social media to moms, birth givers, and families in Georgia right now since this is where much of the misinformation surges?
Yes, that's an excellent question. So I can say that there's a couple of Facebook pages and Twitter accounts, and I think they might have Instagram accounts. I'm not positive, but one of them is Vaccinate Your Family. It's a great place to start. They're a wonderful nonprofit organization whose entire mission is to make sure that parents and children are up to date on their vaccines. The second one is I would follow the American College of Nurse Midwives. We tweet and post on Facebook about vaccines at least once a week. And for a lot of people that are skeptical about vaccines, I think it's interesting. I'm giving a presentation in May on vaccine hesitancy in the racial dynamics of that, and it's been so fascinating and fun for me to do this, the reading on this and where we are with this research. But I think that a lot of people feel like sometimes physicians tend to promote drugs and vaccines without understanding what people's hesitation is. And so I'm going to be biased and say that nurse midwives have always operated under a shared decision-making way of providing care to women and their families. And so I think that and nurses are the most trusted profession in the world. So I think if you're trying to share things, going to a place that shares fun facts and makes it seem relevant or easy, but I can say that those two would be my go-to, is Vaccinate Your Family and the American College of Nurse Midwives. And if I find any others, I will give them to Healthy Mothers, Healthy Babies, and maybe they can share them in their newsletter.
Awesome. Awesome. Next question. Have you seen a lot of COVID-19 vaccines being destroyed, quote unquote, destroyed due to wrong procedures or no one being able to take it?
You know, I've been really lucky in the clinics where I've worked. One of the clinics I've worked in is a clinic in Clarkston, and it's mostly for immigrants in Clarkston. And they literally don't draw it up until the people show up. So that's a drive-through clinic that we did. And like, we would be standing around waiting for 15 minutes so they could go draw up more. Like, they were not going to draw up extra. And the other places that I volunteered are with Fulton County Health Department, and they do the same thing. Like, there were times when I've had to wait 15 minutes because they were like, we're not drawing up anymore until we know if these people are showing up for their appointments. So I have not seen that. I think where that happens, and I have heard of it happening, I think where that happens more often is in small pharmacies and individual clinics that don't necessarily, like, at the end of the day, they have to throw something out. But in large health systems, they, like, if I have a friend that works at Northside Hospital, and at the end of the day, they are running around the hallways going, we have 5 doses left, who wants it? And so they're like in the cafeteria saying, come on down, you know? So I think most larger health systems are working really hard not to waste any vaccine, but it is happening, I think, in some of the smaller places.
Okay, thanks for that, Carol. That concludes all the questions that we have here. If there are any final questions, please ask. Um, well, that concludes the end of our Q&A session. Thank you all for attending. Wait, 1 second. I think we might have a question. Oh, no, that wasn't. Thank you all for attending. Um, Thank you, Carol, for an incredible presentation. It was so informative. A few final notes. A follow-up email will be sent out after this copy with a copy of these slides, the recording, and a feedback survey. The survey will close next Wednesday, so if you are applying for CE credits, please be sure to fill out the survey, and we will provide CE certification a few days after the deadline. So if no one else have any questions, um, yeah, I think that's it. Thank you so much, Carol, for your time. This was so awesome. I'm sure everyone, including myself, learned so much about immunizations and vaccines. It's just been great. So thank you again for attending, and I hope everyone have a wonderful day.
Thank you.
Thank you.